Welcome to the Pathways Research and Training Center's June 21st webinar, How Effective Are Transition Programs for Youth and Young Adults? Findings from the Healthy Transitions Initiative. I'm John Osowski, Director of Dissemination for Pathways, and I'd like to begin with a few housekeeping announcements. Please see the advice on this slide to make the most of your GoToMeeting experience. In particular, please note that during the presentation, all audience members will be muted, but you can send your questions to us via the chat feature. A recording of this webinar will be available online shortly after this webinar ends and will be available from the link shown below. And we'd also like to invite everybody to keep in touch with us at Pathways by signing up for our monthly RTC Updates newsletter. We feature links to Pathways resources like this webinar, as well as news and events of interest to the field. You'll receive an invitation via email after the webinar, and we hope that you'll accept it. This webinar was made possible through funding from SAMHSA, the Substance Abuse and Mental Health Services Administration, and NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research. We're very grateful to our funders today. And without any further ado, I'd like to welcome you to today's webinar, How Effective Are Transition Programs for Youth and Young Adults? Findings from the Healthy Transitions Initiative. And Gwen, would you like to get us started?
I will, and thank you very, very much, John, and thank you to all of you who are spending part of your day with us. I am Gwen White, and I am from the Georgetown University National Technical Assistance Center for Children's Mental Health. I was the TA coordinator for the Healthy Transition Initiative grants, and I have had the privilege of working with the other three presenters on the webinar. They will be presenting or introducing themselves. So we're going to start with two polls. You're going to know who we are. We want to know who you are. And John, can we have the first poll?
Sure thing.
Okay, we'd like to know a little bit about what your role is. If you can please select one of those that you see on the screen. It'll give us some idea and view of our audience. Please select one of those.
Great, and I'm showing about 2/3 of folks have voted, so maybe just a couple more seconds.
Okay, great. Thank you, John.
All right, and we've got about 3/4 of the votes in, so we're going to close the poll.
Why don't we look at it? Yes.
And then let's share the results.
Okay, so service providers and managers are the majority of you, and that's exciting. I am in particularly, as a program person, a real fan of the use of data to inform programs, and we're very happy to see family members and young adults, and this is particularly, we will like to hear from you who are evaluators and researchers about what you think of this data and how it can be used. Next poll, John.
Okay.
Okay, we're very interested in what your hope is of getting through this. So again, we're going to take about 20 to 30 seconds and have you, you need to prioritize here when you're looking at it.
Great, we've got over half the votes in already. We'll just give it a few more seconds. Okay, it seems like the voting is stopped.
Okay, overwhelmingly, you want to think about the effectiveness of programs for young adults of transition age, and that is very exciting, and certainly a lot of what the funders and all of us in the field want to know as we move forward in creating better outcomes for young adults. So now we're going to move ahead, and it is my privilege to turn it over to Diane Sonheimer from the Substance Abuse Mental Health Services Administration, who will further introduce herself. Diane.
Thank you, Gwen. Good afternoon to most of you, and good morning to some of you, I guess, who are closer to the West Coast. As Gwen mentioned, I'm Diane Sonheimer, and my branch, the Child, Adolescent, and Family Branch at the Center for Mental Health Services at SAMHSA, developed, funded, and administered the Healthy Transitions Initiative in response to the growing evidence that young adults with serious mental health conditions were experiencing some of the poorest outcomes in all life domains. We all know that all transitions are difficult, but for young people with mental health challenges, moving into adulthood is made more difficult by the complexity of their individual mental health condition, as well as the complexity of the mental health system and other systems that should be serving them. Next slide, please. Great. The Healthy Transitions Initiative was funded in 2009 for 5 years for the purpose of addressing this concern by creating developmentally appropriate and effective young adult guided local systems of care that traditional services were not providing. Next slide, please. The goal of the Healthy Transitions Initiative was to improve outcomes in the domains that are critical to successful adulthood, as well as decrease contact with the justice system. This also includes developing a sense of autonomy, forming mature relationships with parents and other adult allies, developing and sustaining close relationships with friends, and learning the skills necessary to cope emotionally, socially, and financially as an independent adult. Next slide, please. Cooperative agreements awarded to 7 states for policy and practice change. We recognize that service change at the program, agency, or local level, as we're calling it, is not sustainable without related or concomitant changes at the systems or policy level. Each informs the other. Next slide, please. Okay, here are the states that were funded. They were chosen on a competitive basis through an RFA or request for application. Each state identified 1 or 2 local communities, usually counties, to be early adopters of practice change with the goal of moving towards sustainability and replication around the state. Next slide, please. Okay, this is just a little language issue. Policy change at the state level and practice change in local communities. So we use the term local to describe those counties that were selected to be early adopters of systems change. Next slide, please. Information was gathered informally toward the end of the HTI grants from state reports of lessons learned and challenges, panel discussion at the grantee convenings, affinity group meetings, and phone surveys and listening sessions. The first major impact, as reported by stakeholders, was increase in young adult involvement and engagement. For example, Maine developed an MOU between state-level departments that had young adult members on the state-level policy committee on an ongoing basis. In all of the grantee communities, there was increased visibility and awareness of this population. What we like to say is an increased sense of urgency, letting people know that this is a population with specific challenges, yet poor outcomes. Next slide, please. The grant program saw an increase in partnering with young adult organizations in a very structured way. This included the development of drop-in centers specific to young adults. In Milwaukee, a drop-in resource and support center was opened named Owen's Place in a storefront that also houses a Youth Move chapter. With the input of the young adults, Owen's Place also offers many workshops on life skills, such as applying for jobs, opening a bank account, cooking and budgeting, and brings in various community resources each month. Next slide. When HTI was first funded, the idea of formal peer-to-peer programs for young adults was very new. Another strength of this initiative was a recognition and the importance of peer-to-peer relationships and supports and increase in opportunities for youth-directed leadership. Georgia's local model had a young person with lived experience as part of the transition support team for every program participant if desired by the young person being served. Next slide, please. Gains were made in policy changes that support better outcomes. Employment, housing, and other non-traditional partners were engaged. Missouri changed procedures that reduced the time it takes to open a case with voc rehab. Maine established an MOU that provided detailed guiding principles for all state departments who work with young adults of transition age. Changing a name can also have a big impact. For example, Georgia changed the name of the Office of Children and Families to the Office of Children, Families, and Young Adults. This allowed for a focus on services for young adults up to age 26. Several states also revised their Medicaid plans. For example, Wisconsin Medicaid has embraced the expansion of the age range eligible to receive wraparound Milwaukee services to age 26. Next slide, please. Practice change also had an impact. A value-based service delivery system tied to CQI was identified as critical. This includes services and supports to families and other adult allies, developing a practice model that's sustainable and replicable, services from both the child and adult systems based on individual need and not on a birth date or age. It addresses critical needs in all life domains. Young adults, like all of us, want a safe place to live independently and a means to support that. Next slide, please. Okay, this was a very quick review of HTI. However, at the end, we wanted to develop some documents that would be helpful to you. So we've developed a set that we call legacy documents. The first one that you see is the HTI Toolkit. This toolkit was developed to display documents developed and or used by HTI jurisdictions at both the state and community levels. The next one is the issue brief 1, which is CSTI, the Community Support for Transition Inventory. It's a web-based tool developed by Pathways at Portland State University and made available to the HTI jurisdictions for their use. We hope it's going to be helpful to you. The second issue brief is the SSTI, which is the same thing at the state level. The SSTI is an assessment that gives stakeholders reliable, objective feedback about the extent to which the state has developed the capacities to support local efforts. Coming soon is also an issue brief 3, as you can see there, Healthy Transitions Initiative, Youth and Young Adult Outcomes. We're going to present some data in that from both the NOMs and local level evaluations. Now I'd like to turn the webinar over to Nancy Koroloff.
Thanks, Diane. This is Nancy Koroloff. I'm a researcher at, excuse me, I'm a researcher with the Pathways Research and Training Center in Portland, Oregon. And I'm going to talk very briefly about where this data came from and a little bit about what the set of young adults who got services through HTI looked like. And we're transitioning here. Diane was talking about infrastructure and policy changes that we saw as a result of the grants that were given out. Now we're going to focus for the rest of the webinar on client level data. And this is data collected directly from the young adults who actually had entered into a program in one of the 7 grantee sites. So we're looking at the client level data that's collected through the national outcome measures, the NOMs, and I think many of you are very familiar with this document or the child one because you've probably been on the interviewing end collecting data with that instrument, and others may have actually done some analysis of the data from their particular state. So hopefully you have some sense of the kinds of questions that are asked in the NOMs. There are 8 domain areas and 75 questions. The NOMs is to be administered at baseline, so once the young adult is entered into the transition program, and then again at 6 months for as long as the person remains in treatment. If they leave treatment, a discharge NOMs instrument is to be filled out. This study is going to focus on the change across time for four key domain areas, the four key outcome domains contained in the NOMs. The daily functioning, overall health is another one which we're not going to address today, social connectedness, and mental health symptoms. And we'll give you more information about what's measured in each of those. So next slide, please. And again, many of you know this information, but for those of you who aren't familiar with the NOMs and its data collection process, the data collection varies across grantees, so even each local community may have a slightly different approach to exactly how they get those interviews. Most often, the data, the NOMs, is completed by the transition facilitator who is interviewing the young adult, and that's particularly true at baseline. In some states, the data, the follow-up data was collected by a research interviewer, and there was one place where all the data was collected by a research interviewer. Next slide, please. In terms of the data, how we cleaned the data, we didn't use any of the data that was collected administratively, with exception of, we did look a little bit at the discharge data. We excluded, there were a few youth, 9, who were actually under age 18, which is below the age limit, so or under age 15, I'm sorry. We excluded anybody who was younger than 15, but we kept in 5 youth who were 15 at baseline. And then for the outcome analysis, we included cases who had either a 6th or a 12-month follow-up. Next slide, please. So this gives you the amount, the data, the size of the data set. At baseline, we had 1,542 completed baseline interviews. At 6 months, with attrition, there were 666, which is over 50% that did not have a 6-month interview, and then it goes down even further by 12 months. And we'll talk a little bit more about what does this attrition mean. Next slide, please. This is just to give you a sense across the 7 sites how big each site was. No one site was dominating. The biggest site had 20% of the total number of NOMs. The smaller 2 had 10%, so a reasonably even distribution. And you can also see the goal in the right-hand side is the goal that was set in their application. And most people met or far exceeded the goal, with a couple of exceptions, like number 5, where probably the goal was a little bit ambitious, since they have a healthy number of participants. Next slide, please. And I'm going to whip through these kind of fast so that we can get to the outcomes. 49% male, 51% female, with a very small amount of missing data. Next slide. This is the age distribution. For the most part, these young people are coming in between 18 and 20 years. Those are the you're getting a few below that and above that, and almost nobody who's 24 to 26. So as they enter, they're most likely to be in that 18 to 20 age range. Next slide, please. This gives you some idea about ethnicity and race. About 8% of the total, there are a few missing, said that they were Hispanic or Latino. And then if you look at the bottom of that slide, this is the breakdown by race. About 31% were black, 53% were white, and small numbers in other categories. That's not, I mean, that's not a bad diversity, given that these were states, you know, that ranged across the country, and many of them had very little diversity in their states. So this is, I think this is a good outcome. Next slide, please. 16% said they were heterosexual. Now, if you look at the missing, you can see that many young people did not provide this information at baseline. And when we presented this data at a conference, we had a really interesting discussion about whether that number missing is because the young people didn't want to answer and said they wouldn't answer, or whether the person doing the interview, which was probably the transition facilitator, didn't want to raise that issue that early in the in the relationship. Next slide, please. This is a set of questions that ask the young person, did any of these things happen to you in the last 30 days? And to some extent, I find it interesting that the percentage that said, no, this didn't happen in the last 30 days, for most of these indicators is very high. So for example, 91% said they had not been physically hurt in the last 30 days. 90% said they hadn't been homeless in the last 30 days. I think the one that I'm drawn to looking at is the violence or trauma. And here 25% said that hadn't happened in the last 30 days, which would mean that 75% had experienced violence or trauma. And the other, but there's a very small number of people who answered that. So the percent based on, only 471 of the 1,500 actually answered that question. But of those who answered, 75% reported that, yes, there had been that kind of an incident. The other one I think is interesting is this intake homeless, 21 plus days. There were 48 of these young people who basically were homeless most of those 30 days, those last 30 days. It's a very small group, but I think it's a group we may want to take a little more, a little closer look at. Next slide, please. And again, I'm not going to show you all of the information about these various descriptives. I pulled out employment, again, to give you a sense across the 7 sites, or the 7 grantees, how fairly similar they are. Employment, most of these young people were not employed at baseline. It ranges from 2 to 8%, but it's very small. Most were unemployed or other, which could be something like being in school full-time or retired is another category. And that one ranges from 45% up to 66%. So you can see, and even the missing, there's a fairly similar across the 7 different grantees. And that becomes an important factor as we look further into the outcomes. Next slide, please. Of course, we and all of you probably, and many other people want to know, what about all those young people who don't have a 6-month follow-up interview? What happened to them? And are they different? Are they very different in some way that we need to know about? Is there something that we could be doing for that group to keep them in services a little longer? So just a few things here. The gender, you can see the gender between the no 6-month assessment and yes 6-month assessment. Gender is very similar. Race and ethnicity, look at the percentages, they're really very close to each other. So next slide, please. Well, Chris is going to talk a bit more about how she tested these differences. And here, this one I just find fascinating. These are the outcomes. And one thing that I hear sometimes folks who are in the field say, well, those who drop out before 6 months really have much more serious problems. That's from their observation. But if you look at their scores on the mental health scale, they're almost identical to those who stay in. And the same thing is true for daily functioning and social connectedness, physical health. So Chris, do you want to chime in here now and maybe introduce yourself and then speak a little bit more about this attrition data?
Sure. Thanks, Nancy. Hi, everyone. I'm Chris Painter. I'm the Director of Evaluation at the Center for Mental Health Services in the Division of Service and Systems Improvement at SAMHSA. That's kind of a mouthful. So we did want to take a look at, number one, differences based on different demographics, based on different the different scales at intake, and then also between the different sites for our analysis. So we did one-way ANOVAs and chi-squares, and so Nancy already talked to you a little bit about some of the demographic data. These are mean scores that you're looking at baseline. So again,
we thought, we kind of expected, based on what other people had mentioned, that we would have differences between those who got a 6-month and those who did not get a 6-month. And as you can see, the baseline mean score, average score, is pretty close on all 4 of these measures, and there is no statistical significance in the difference between them. And we'll talk about the high attrition rate later, because obviously we do have that as a limitation of the study. Next slide. So on the NOMs, when at the time of discharge, it asked for the reason for discharge, and here you can see that kind of equally close. We had 225 who had no contact within 90 days, so they were discharged, and 221 that mutually agreed upon cessation of treatment or completed program. That means that the young person did successfully complete the program, and so we had 221 of those. 196 withdrew or refused treatment at some point, and then you can see we have a significant amount of missing data with 764. And again, we'll talk about that a little later. Next slide. So we used a linear mixed model to analyze the changes across time, and we looked at intake 6 months and 12 months. And again, if somebody was missing their 6-month data, obviously we did not include them in the analysis. There were a few, maybe about 5 or 6, that had an intake, were missing their 6-month, but had a 12-month. So we did include them, so they show up in the 12-month analysis. So using the mixed model, it allowed us to account for the fact that we do have covariance between the time, and that at each time point, the differences, the variances, were unequal. And we also looked at some covariates. We looked at time, so the intake 6 months, 12 months. We looked at gender, race, ethnicity, and educational levels. Next slide. And I'm not going to talk about all the different statistical methods, but I know there are some evaluators on the phone, and so if you're interested in that, you can surely ask, and I'll let you know at the end. So controlling for age, gender, race, ethnicity, and education attainment, the only factors that we found significant associations with were age and gender on mental health symptoms and overall health. And as Nancy mentioned earlier, that's not one of the key things we're presenting here, but full disclosure, part of that, and not part of that, I shouldn't say that, there was no significant change in overall health, and there are many factors that could account for that, one being that it was only a 5-point Likert scale, 1 question, and there's not really an opportunity to have much variance there. In looking at models with the statistics, age and gender, even though there were significant associations on mental health symptoms, in the final model it did not have effect on the outcomes. The outcomes were the same with or without those included in the model, and we had a better model fit with them not in the model. Next slide. So the first scale we'll talk about, an outcome, is the social connectedness scale, and these are 4 items that are included in the NOMs, and the response categories range from either strongly disagree to strongly agree. So people respond, I am happy with friendships I have, I feel I belong to the community, etc., based on those response categories. And a score of 4 to 20 is the range, so the items are summed to get that. And higher scores mean that the young adult has greater social connectedness. Next slide. So here, we said higher scores mean greater social connectedness. So as you can see, from intake to 6 months and then to 12 months, those scores do increase. And if you look at the right-hand side, you can see that from intake to 6 months, it was a significant change, and it was not a significant change from 6 months to 12 months, but from intake to 12 months, it remained a significant change. So they continued to get better as time went on. Next slide. So the next one is the mental health symptom scale. And this is asking during the last 30 days, how did you feel? And it asks about nervousness, hopelessness, restless or fidgety, depression, everything was an effort or worthless, and then the response categories were 0 to 4, with 0 meaning none at the time and 4 meaning all of the time. So lower scores are better, and this scale ranges from 0 to 24. Next slide. So here you can see that we wanted the scores to go down, and indeed they have. They went from a mean score of 8.97 to a mean score of 7.9 to a mean score of 6.8 at 12 months. And on mental health symptoms, it was significant improvement from intake to 6 months, and we also had a significant improvement from 6 months to 12 months. And of course, the significance from intake to 12 months remained. So people's mental health symptoms were improving across time. Next slide. And then the daily functioning scale. So this scale consists of 7 items from the NOMs, and the response categories range from 1, strongly disagree, to 5, strongly agree, and then the totals are summed to a range of either 7 up to 35, and on this one, higher scores mean much better daily functioning. Next slide. So again, you can see that we did have some significant improvement across time. Scores got better in daily functioning, which is what we were looking for, with a mean score of 24.91 up to a mean score of 26.33 to 26.9. And we had significance both from intake to 6 months and 6 months to 12 months. So across time, people continue to get statistically significantly better, and then we had, of course, statistical significance from intake to 12 months. Next slide. So in all, across all 3 of these scales, with the final model we ran, nothing was significant. I mean, everything was significant in mental health, daily functioning, and social connectedness. Again, nothing was significant in the overall health. And I think I forgot to mention that in the final model, the only factor that we included in the model was time, and that was because none of the other factors interfered with the findings. Next slide. So the limitations, and obviously there are limitations to this data. I mean, it does show that for the youth who we were looking at from intake to 6 months and then from 6 months to 12 months, that their scores had a significant improvement, statistically significant improvement. But the fact that this was a secondary data analysis, so we had no control over the setting up of the study or monitoring how the data was collected. there was the high attrition rate between baseline and 6 months, and actually high attrition rate even just with that intake, and we don't know with a significant number of those what happened to them because there was nothing past that intake. They did not have any kind of a discharge that provided any data that we could use. Again, Nancy talked about that across the sites there were different people collecting the follow-up data at different times. So we do not have a way of knowing how people were trained in the data collection. We didn't have the ability to monitor the accuracy of the responses or to do anything with the fact that we had missing data. We also did not know anything about the services that youth received as far as frequency or duration or who provided the services. We knew which services the young adults got, but we did not know who provided that service, if they got that service ongoing, or if it was a one-time thing. So that was a problem. So while we do have some significant improvements, we do have to keep that in context with our limitations, but also keep in context the analysis we did just to look at the differences in those who did not have a 6-month and those who did. Next slide.
And Chris, before we move on from this slide, we did get one question that related to it.
Okay.
In the first bullet, you mentioned data excluded if collected administratively. We did have a question for a little more clarification around that.
Sure. Okay, sure. Thank you. That's actually a good question. The data, when it's collected administratively, that means that somebody from the program or the evaluator doing data collection completes a form basically just saying that the person is no longer in services and you're not asking any follow-up information from the young adult on things. So there's a lot of missing information. It basically is we lost them to contact or they moved or different things like that. So we don't have a lot of information on those folks.
Okay. Next slide then.
Okay. So one more slide. There we go. So again, we did see a reduction in mental health symptoms, in daily functioning, in social connectedness across time. We did see that there were no significant differences at baseline between those who made it to a 6-month follow-up and those who did not. Our initial analysis and just looking at the difference in the sites, there was not much variation between sites. It was pretty much the same at baseline. And so, next slide.
Okay, this is Gwen, and I'm going to help facilitate a conversation now, question and comments, and I really think we have a good chunk of time, and we have lots of people on the phone who are experts. I think first we can go to a question that was posed on the screen, and that is a question about effective services to support transitioning into higher education. And I'm going to take a stab at that first, and that is to say that many of the Healthy Transition Initiative communities had or incorporated in the use of a supportive education and supportive employment personnel. So they had teams that actually had a supported education person as a part of their team who worked very closely and as a part of the team on meeting the young adults' education hopes and dreams and also their employment. And I think that that's very critical. I'm assuming, I cannot see the list of attendees, so we have some participants on the phone who were part of the HT community, and I also know that we probably have people who have had successes around transitioning to higher education. So, John, are the lines unmuted? Can people contribute to answering this discussion question?
Well, there's 130 folks out there.
Okay, so
probably
we're
not a good idea to.
Okay.
Yeah, but if folks would chat in, and it seems that they do have a few growing list of questions that we can get to. So please chat in if you do have a question.
Yes, please do. And John, I'm not seeing those questions. So,
Okay.
but
I was just going to throw out that we know that the majority of you were interested in what this data could tell us about effective services. And I heard things certainly around housing and education being very important parts of services to young adults. But we as the presenters are very curious about if you have ways to use these findings and thoughts about how the information could be used. And I'm going to say that, John, and then hope that you'll fill us in on what some of the questions are.
So, and while we're waiting for questions, I'd like to ask Chris, if you could go back to the mixed model repeating measures test model that you did, and there were a number of covariates or fixed factors that we thought would make a difference that didn't. And I think as what you said is that the only thing that stayed in was time. But can you talk about, particularly about the grantee and the community, but talk about some of the other covariates that we tested and that didn't seem to have any effect on the outcomes?
Okay. So you're talking about?
Particularly site. That was the one that surprised me the most.
Yeah, I think that surprised all of us a considerable amount. So I used a one-way ANOVA just to look at the differences in site, and I looked at the differences at their baseline levels, where the people who came in to services and then the people who stayed at 6 months, were those people, they seem to have differences in their levels of mental health symptoms or functioning or social connectedness based on the different sites, and there was very little variance and nothing was significant between the sites, and I was surprised about that.
Thanks.
And Nancy, does that lead to other curiosities you have?
Well, that was the main covariant that we looked at that didn't work out. I can't remember, Chris, were there any others that were that we discarded after testing them?
Well, of course, we ended up not using gender, race, ethnicity, age, or educational level because, again, some of them weren't significant, and then the others who really didn't make a difference in the end on the mental health symptom scale overall. I think the other thing that really surprised us, and we both have mentioned this already, that differences at baseline just between those who stayed in and those who left services were so similar, and I found that to be just really surprising. I would have expected it to be different.
So, ideas, is there anything that is popping up to you, John? It's really critical to have our panelists discuss.
Yeah, we have a bunch of questions that have come in toward the end here, and I think we can probably address them in the order they were received. So the next question that came in was regarding, do you have information on if young people had ever experienced a trauma, trauma being defined as adverse childhood experience, like those listed in their lives pre-program, and how many as a comparator rather than just the last 30 days?
Nancy, you want to take that?
Well, one of the criticisms of the way these questions, some of those questions are asked, is that it's only in the last 30 days. And certainly some people have commented, well, for things like intake to a hospital, you really need to look maybe for 90 days. In this instrument, we only have the last 30 days. And that's the only data we have about trauma and violence. Now, some of the individual states, their evaluators did a much more thorough analysis and had additional data about violence and trauma. I think there's one or two that had some interesting information suggesting that the level of violence is pretty high if you look back a little bit further. But it's pretty high in the last 30 days, so.
Okay, the next question, and I think we may have touched on this already, but it couldn't hurt to reiterate. Looking at differences, did you look at differences in outcomes across states?
Yes, we did. That was in, before running the mixed model, we looked at it using one-way ANOVAs across time, across states, and also across sites. So we didn't know, we looked at states, and then within states there were different sites. We also looked at sites differences as well.
And here we're using the term site to mean local community. So
not the state, but the communities in which the states were implementing change.
I think there were 13 of those, something like that. So there were 7 states, and then within some states there were 2 local communities. And Chris looked at both of those. And there was no significance on any of them, right?
There, within, and I have to go back and look at the data, there was no significant differences that really had any effect. So when it might say something was significant, but when you dig down into the data, what was significant really had more to do with a sample size, kinds of differences, not major differences. But I would have to look back at the data.
Okay, so that sounds like a larger question too. The next question that came in was regarding all 3 of the scales. You indicated there was significant improvement. Does your data tell us what intervention made it so successful?
No, and I think, as I pointed out in the limitations, because we do not know, we know kind of a mixture of services, but we don't really know how much of that, any of those services they got, and so there's really not much we can say about it. And I think another limitation, which I didn't mention, is, so we did see significant improvement, but I think down the road we really want to look at, okay, so we have statistically significant improvement. What does that mean in the real world to young adults who are receiving services? Does that have a clinical difference? And so I think in the future, really being able to tease that out, and also maybe do some qualitative analysis just to get more of that lived experience from the young adults who have participated, because that is a serious limitation.
Okay. The next question is just about getting information on the scales. So is there a way to get information on the scales from the NOMs tools and how they were scored? So is that information accessible somewhere?
It is. I can send a link. It's on it's a track SAMHSA website, and I don't know it off the top of my head. Maybe Diane does, but I can surely get that site and send it out, and you don't have to enter the site. You don't have to sign in, log in order to get the information. And it has a question by question for the questions, how the questions were asked, and then code books along with it.
Great. And you know what we can do, Chris, is kind of collate these links into another resource that we post with the webinar when we archive it. So if you'd like to send that link to me, I'll make sure that it's with all the webinar materials. And this might be a good time just to put that link up here on the screen so people can know that the slides and the recording and all these additional resources will be available to you probably later today from the link you'll see on your screen now. I think we have time for a couple more questions, and we do have a couple of them. So continuing on the limitations, it seems that there was a lack of control or comparison groups. Do you have any information about the expected 6 and 12 months changes in these scales for transition age youth who did not receive assistance?
No, again, a limitation. Gwen, I'm sorry, was that you?
Yeah, I was just saying no, but go ahead, Chris.
Yeah, yes, it is a significant limitation that we don't have that information. And I think that's kind of, for me, one of the takeaways is I think if we can really look at ways to collect the data after I'm used to working on system of care evaluation, so youth is stuck in my head, and I know these are young adults. But if we could find ways to really collect the data after young adults leave services and see what really happens, and as well as have some good measurement tools that look at the clinical improvement, I think that'd be very important.
And I might add that in the current set of funding, which is the NITT Healthy Transitions, now is the time Healthy Transitions, the cross-site evaluation has a plan to, in fact, continue to collect data from a sample of the participants after they leave services. I mean, I think we all know from experience, both in system of care and other places, that getting that follow-up data is difficult when the young person is still in services, and it's even more difficult when they're out of services. And so part of the balance is how much money and resources do you want to spend on trying to get that data.
Okay. Do you think we're ready for the next question then?
Sure.
Yes.
Okay. And this one is regarding the NOMs measures themselves. The asker is, I guess, wondering if they're psychometrics and how they were developed and tested, and you know, what lends to the effect size and meaningful reliable change calculations.
That's a mouthful. They have been tested, and on the same track website there's information around that. But they're really, the thing about the NOMs is they were not meant to be measures of clinical improvement across time. They were meant to monitor how things were going, but they were never meant to be a clinical measure. So there are serious limitations around that as well. Nancy, do you have anything to add?
There was a lot of work put into them when they were first established, and I think they've been modified a couple of times. But I think what you just identified as the limitation. It's the most data that we have that's common across all participants, but it's not all the data we'd like to have, and I think that's just the way it is.
Mm-hmm. And hopefully, with now is the time, that will change because they do have some additional measures.
Right, and we'll include, I guess, and just reiterate for folks that the link on your screen now will be where you can find a link to those kinds of resources and can dig into those kinds of questions a little bit more deeply. The next question is, it's like a comment and a question. So these results basically assess over time for people who receive services. But what assumptions can we make about what the services were? Do we have any more details about that?
Nancy, what are you thinking on that?
As Chris said earlier, we only know the mixture of services. We don't know how much, how long, or anything else. But we have not yet looked very much at that mixture of services. So it's one of the things we might take a little closer look at. It's just not going to tell us a lot. I mean, so that's all.
Right. So I would say there was a relatively high percentage that got medication management and case management. Those seem to be, those are sticking out in my mind, not looking at it right now. Those seem to stand out as something that were utilized higher than other things.
Okay. I think we've got time for just a couple more questions. We're heading toward the end of the hour here. Here's one about the statistics as well. I understand the changes, I guess, among the measures were significant, but given that for some of the measures the values were not all that different, could you talk about how meaningful you felt they were?
Right, and when I was talking about needing to look at clinical significance or look at how that really, what did that look like in real life, that's really what I was talking about. So we did have these changes and they were statistically significant, but there really needs to be, the next step will really be to look at what does that mean. So I improved a percentage on a measure. What did that difference did that make in my life? And I'm really hoping that with this, with the healthy transitions, that they will be able to take it to that next level. Nancy, you have anything, or anybody else?
I think that's the one that we're still trying to figure out is you know, if at intake you had a mean say mental health score of 8.97 and it went down to 6.8 at 12 months, you clearly have fewer issues with your mental health symptoms, but how meaningful is that? So it's a good question, but not one I'm not sure that we can answer it with this data. But as Chris said, this may be one of the things that the NITT evaluation can look a little more closely at. Because we'll have NOMs data on all those young people too.
All right. I think maybe we have time for just one more question. And again, given that there doesn't seem to be a high level of specificity about the services that were rendered, maybe this is a hard question to answer. So you'll do your best, panel. Have any services been identified as effective in reducing criminal justice involvement, arrests, among young adults receiving these services?
Well, there are in the field, not in this study, but there are in the field, I think particularly of MST and the work that's being done by Marianne Davis out of her research center at UMass Medical School. They've tested and have looked fairly closely at the use of MST for young adults who have both a criminal justice record and mental health issues, and have had some success with the modification. So there are studies that are being done by other people. This data doesn't give us any insight into that.
Okay.
Are there others, Gwen? You may know of some others.
No, I think I thought of Marianne too. So I think that that's the main thing. It does fit into where we started of people being interested in what does this tell us about effective services. And I think some of those areas are areas to be sure are built in a broad menu of points of services and supports based on the needs of the young adult.
And I think for maybe not, I can't speak to the age group. I'm thinking it's younger than maybe up to 18, but therapeutic foster care is another one that has been used successfully, or there is some evidence to support that it's effective dealing with youth who have criminal justice issues.
Okay. Thank you once again, everyone, for being involved. Please look at the information that will be posted. We do want you to be thinking about other ways to use these findings, how the NOMs data can be used in communities that are looking at change initiatives for this age group, and ways certainly that funders can be apprised of this information. And John, I think maybe you have some things to remind people of?
Yep. This is all the time that we have for today. I wanted to thank our panel and thank our audience as well. We will be, again, posting all of the recording, the slides, and these resources with the links at the link that you see on your screen. We'll also be sending a follow-up email soon to those of you whose questions we couldn't get to today. And basically, thank you all for participating, and we hope that you will join us again. Goodbye, everyone.